Yes, you're gonna have people turn their backs, but it's time for us to keep it real. Just keep talking that real, bro. Do what you do. I know what you do, so keep doing that. Talk the real.
The HBI lads will see you now. See you now. See you now.
I don't want to cause no problems. I just want to live my life, but I keep on hearing about nonsense.
All right, game on. So we are. That's how hard and fast we're going today. We're talking tendons because everybody loves tendons. That's creepy.
Sweet.
I like it.
Some sweet tendon talk, TT tendon talk.
All right.
And you're talking
Because
about
it is. Oh man, I was talking about like one of those video I saw recently. I think it was from a 2018 conference. I do think it could have. I think it was a med conference, but there was a physiotherapist talking. They were looking at like ultrasound, I believe it was, of tendons in like tendinopathies and things like that. Because traditionally there was this idea that in like a tendinosis and there was like a reduction in like healthy cells within the tendon itself. And what they actually showed when they
tenocytes.
when they did repeated ones was there was the actual tendon itself. Obviously there was thickening, but the volume of like healthy tendon was vastly like increased compared to a uninjured tendon. It was quite an interesting thing, right? Which obviously just as always further supports the idea that we want to get load back into these areas as quickly and as efficiently as possible. But we're jumping ahead a little bit there. Let's talk basic breakdown, right? Because I know one of the things I commonly see in my clinical practice is different forms of tendon issues, you know, your classics, your patellar tendonitis, your Achilles, golfer's elbow, tennis elbow, all these kind of fun things. So, I mean, I'm sure for our audience who is predominantly clinician-based, a lot of them understand it, but do you want to have a quick run through there, Benny or Dan, just on the basics of, tendon-based sort of injury?
Yeah. We could probably go to a little bit of anatomy first. Everyone knows, I guess. I think this is where we should do some more ask maybe the audience what they want to hear, because, people in our position, like, you can easily skip over basic knowledge that you think is common knowledge, and you're not just bypassing a whole heap of learning stages and just jump straight to the end. But I think if we start off with some basics, so everyone, I think a very important thing about tendons is not only obviously their ability to withstand tensile and compressive loading, and obviously their connection between the muscle and the bone. That's what anchors the muscle to the bone. In our industry, because we deal with pain and injury, I think talking about the vascular supply and the neurological supply is pretty important. So as we know, tendons are designed to withstand tensile loading and some compressive loading. Depending on what tendon it is, will depend on, what it can tolerate and the capacity for it to tolerate something. And depending on, I guess, again, location and structure will also depend on like vascular supply. And as we all know, the amount of vascular supply that a tendon has will definitely influence the rate of healing. So as Nathan touched on before, there's the old argument, is a thick tendon an unhealthy tendon? And if your tendon is thickening, does that mean my tendon is getting more likely to snap or to degenerate or to wear out or whatever that may be? But there's the old analogy is that they use like the donut analogy, which is basically you've got the original tendon, and if the tendon's starting to thicken, it means that you have obviously some dead or degenerative tenocytes, which is the tendon site. And then what the body is doing to try and reinforce the tendon or repair the pathology that exists, it's creating new tendon cells around the degenerative tendon cells or the dead tendon cells, and then it's creating like a donut. So the inside of the donut is more the dead, and the outside, the thickening of the tendon, and the more fibers that are getting laid down, the more cells that are being created is more the healthy and new tenocytes. So I think that I don't know if I jumped too far forward there, but it's probably important to understand, why do tendons get sore, and what are, I guess, maybe common injuries around that, tendon pathology, and then how do you describe tendon pathology, and what type of relative rehab should you give someone at what certain stage, and when should you deload and when should you reload, and that sort of thing. So I'm just ranting here, and I think one of you boys is ready to jump on. But yeah, I think anatomy is important. And then obviously location and characteristics of the tendon will dictate function of the tendon. So someone jump in. I'm rambling.
Good, mate.
Go ahead, Dan. Yeah.
Where are we going now? Management or diagnosis?
Diagnosis, I reckon, would be good.
Yeah. Yeah, I mean, I guess mainly it's going to be, like, I find it's more case history dependent in terms of, like, trying to diagnose, like, unless you're doing imaging or something like that, you can't really be 100% gold standard, but more so for me personally, it's just about case history, trying to figure out what the background is, what tasks they're doing, what they need to be doing, and then also looking at recovery time. So as you mentioned before about, the vascular supply to a tendon versus a muscle, you're generally going to see a longer fatigue between sessions or longer recovery times, which is also going to play a role in then, our exercise prescription. So if we're prescribing stuff that's more like, I guess, for a tendon, like generally what I'm doing is thinking I'm prescribing something and then seeing how they respond during the session, like kind of pain scales or like differentiating between discomfort and pain. So generally for me, it's like anything below a 4 out of 10, kind of acceptable. If we start going outside that 4 out of 10, moving away from, useful discomfort more towards pain, kind of telling me, intensity or volume's too high. And then also like the same scale over the next, 48 to 72 hours in terms of how they're pulling up and recovering as a gauge of like, if I'm, loading it enough or not loading it enough essentially. So that's generally how I approach it. And then obviously like from an assessment point of view, not really direct assessment as much. So like if someone comes in with say like a patellar tendinopathy or let's say bicep tendinopathy, like not so much looking at the area directly, but more so thinking about joint function above and below. So like a lot of times, I think we talked about it with the knee the other week, like if you're looking at the knee or the elbow with like tennis elbow, golfer's elbow, you got hinge joints that, primarily designed to move within one plane. If you look above and below and the hip isn't rotating very well, the shoulder's not rotating very well, now you've got a lot of torsional force or rotation force going through a joint that doesn't necessarily like doing it. It's going to contribute to that overload at the joint and more that like chronic overload versus acute overload, which is obviously generally more tendons. So kind of like a concurrent approach, I guess, of like looking at addressing the underlying factors of what's happening in other joints and trying to restore joint function, mobility. And then when you're doing stuff directly to the tendon, more so just load management. So, phase one, generally unloading and looking at lifestyle factors. So, recovery, nutrition's a big one. And, obviously just decreasing volume intensity initially, and then gradually looking at just basic progressive overload principles, monitoring fatigue and recovery, and just gradually, really slowly progressing them back again. So nothing really magical, just kind of making sure you follow the basics and don't miss the underlying factors. I don't know what Nathan's point of view is, but I think the biggest thing I see is like maybe a lot of people just go direct, and like the rehab's not necessarily bad, like the progressive stuff is not bad in terms of like the tendon. However, sometimes missing those underlying factors, like just doing stuff at the elbow and the knee without looking at the shoulder and the hip. And if you don't really address that path of least resistance, you can just keep recurring the same injury because they're not actually reducing the relative load going through the joint. It's done.
No, 100%. I agree. Absolutely along those lines, right? Like usually most of these injuries are just a sign of an area that's taking more force than it should be, right? And and we're seeing a reactive issue due to that. And of course, we can have variation in tendon issues from, your more acute, your chronic styles to your more like all the slow burner or the high burner, where you've got low-grade inflammation just sort of sitting there and you almost need to stimulate more inflammation to improve the healing process. Or you can have just a really acute inflamed one that needs to be deloaded. Because you do see a lot of incidents with, especially like chronic low-grade tendon pathology, where deloading has little to no effect, right? It is not the issue. And I've been through that myself with
stimulate.
Yeah, exactly. Right? I had bilateral tennis and simultaneous golfer's elbow from just a lot of overload work, which came from heavy powerlifting cycle with, mate, I wish that was the case. From, like having the Schumann's just getting real tight in the upper back, running into a comp and not listening to the body because I was busy. And then I decided I basically taped most of the upper body out. Literally within 2-3 weeks, there was no change. I put heavy loaded bench back in, and if anything, it felt better. So it's, with a lot of these injuries, like you said, Dan, like without imaging, and even with imaging, you can't always be 100%. It's a lot of almost treatment and diagnosis by exclusion, right? Like we're going to hear things in the history, we're going to see things in the evaluation that suggest it's that, and then we're going to instigate treatment protocols and react based, like you said, on how the body reacts. And I think the most important thing, especially when you're talking to a patient about these, is understand this shit takes time. Like we're talking good months usually before you get, good resolutions, and especially with a lot of like the little subtle ones like your elbow. I find like sometimes it'd be a good 6 months for like absolute no pain, and usually that's because the person's pushing, right? Like if we're working with an athlete, they're still training and they're still going. My powerlifters, right, especially in a mixed grip, they're still seeing a lot of rotation across it, even just holding the bar in the back in a low bar position. It is, there's that constant discussion we have around health versus performance, and a lot of the time it's management rather than treatment. So you're just trying to minimize the effect on it rather than actually fix it, because we're in the middle of a process, and if we to stop and do that, we would have to have get rid of that performance goal we have. Yeah, exactly. All right, so I do think it's a really important balance. To understand for people. And there are a lot of accessory options with like in terms of like probably PRP and injective therapies I've seen have some pretty good results concurrently. I myself have had an Achilles issue, which prolotherapy really helped us to move on top of. And like it didn't fix anything, it gatewayed it for me to be able to push further and move through it, right? And that's where more invasive interventions have a place. If we have, again, like everything, it's about understanding all of the influences going on, as Dan talked about, right? You need to have a full understanding of, like, one of the most quintessential things is if you're not asking that person about their training load, well, we're already wasting time.
It's just this, I think it's important to touch on maybe the stages of like the degeneration, the stage of the injury, or whatever it may be. You boys both touched on, which can seem very confusing until you have some experience dealing with both acute on chronic flare up versus a straight up acute flare up, will then dictate, all right, what steps do I need to take in order to then create enough stimulus to create the adaptation, or as you both said, to deload, to give the tissue time to heal and regenerate, and then slowly reload again, and sort of try and go through the history and say, all right, well, you may be fucked up here about 4 weeks ago when you had a 50% increase in your load, and it's taken 4 weeks to rear its head. And now this is why you got your problem 4 weeks down the track. And you come here and you might say, oh, I didn't do anything. It just started flaring up, a gradual onset, et cetera, et cetera. Then I think you boys both touched on it. It's important to sift through the history of the training load. And they said it like, if you haven't even touched on a subjective question asking about someone's training load and history of mechanical or physical loading, and said you're not going to have much of an idea how to even diagnose a tendon issue in the first place, because as we both know, as we all know, a chronic overloading of any type of tissue will create degeneration over time, and soon enough the inflammation and deterioration or the damage to the structure, if that's superseding the healing capacity and the vascular sort of supply to the area, then of course you're going to end up with an injury over time. And that happens to, whether we're talking stress fractures to bones, small tendon tears, or we're talking, muscular overload or any sort of injury, that sort of the same principle exists. So I think that let's say someone runs through a bit of a as you boys said, like Nath, you said you had some golfers as well as some like bilateral golfers in tennis, which sounds like it's terrible. Like common flexor origin for all you nerds out there, and common extensor origin tendinopathies going on. And so let's say someone's mid-season or they're about to, they're warming up and progressing closely to an event, and you got some bilateral problems going on. What were your first sort of steps in trying to manage that?
Like obviously
managing the load.
Yeah, obviously deload was the first thing that I looked at just to see how it affected things, right? And in my case, I realized that it had limited effect. The other issue I have as a chiro with adjusting is there is a lot of tricep extension and movement constantly going through the arm. So there was a secondary load that I probably hadn't accounted for, and I'd had quite a significant increase in volume as a practitioner over the previous months, coinciding with this training, which had no doubt had a major effect. And then I also had a newborn that I was carrying around constantly, which again just tripped it over. So obviously, first step is that deloading process to sort of see how that affects things and see if that's going to be an appropriate response in this case. From there, like I had a bunch of manual therapy work through there, both from like adjustment mobilization through the various areas, upper back, shoulder, all the way down to the forearm, bunch of instrument assisted release, a little bit of dry needling, stuff like that. And that semi-regularly just to try and see how that would promote and sort of give me that space.
Facilitate, yeah.
Exactly, right. And then went back in for a more rehab process. So usually started putting a lot of isometrics in, a bunch of eccentric work, especially I found a lot of, for the arms, eccentric hammer curls really, really nice. Some high position bicep curl to really work on that humeral depression, a few other things like that. And then slowly, I did my main strength work still, but then my accessory work was all that rehab sort of volume. And then I moved back to really it was lightweight, high volume concentric. So one of the things I would do was 100 rep set at like a single plate on the both like cable curls and press downs. So it'd be like 50, holding it, rest for a moment, 25, rest, 15, 10. And one set just burned through. I found that punch of blood flow volume into it as a sustained contraction really helped. And then did that probably for a good, I'd say that combination for a good 6 weeks around the other strength work with continued manual therapy sort of work, and then was able to go back to concentrics and sort of roll through.
Took a while.
I still get the occasional like lateral right elbow in like if I start to get real heavy in mixed grip. But again, that stems from a mixture of, Schumann's, and then my left elbow doesn't fully extend anymore from when I cracked it a while ago. So there is an undue amount of stress that does come through there. The other thing I did find as a bit of a cheat, because I really wanted to I was moving into a comp not long after. I found just getting some compression around the elbow really helped. So I literally had like a one of those really cheap sort of like they're meant to be used for blood flow restriction, like tourniquet things. I literally just like strapped that around the elbow on the right hand side on my weak grip when I pulled, and I had no pain with that. Right. Obviously, I wasn't pulling a lot of volume work at that time, but it allowed me to still get the work I needed in. And then as soon as I sort of finished that comp, I deloaded all back and just ran it back up. I think I did pull trap bar in a neutral grip for a long time, neutral grip pull-ups, all that kind of stuff, just to try and build some capacity around the joint, and then came back to more of a challenge from the rotational aspect.
Perfect. I think that leads in perfectly to Dan touching on like structures above and below and in the trunk and whatever not. If you're getting a structural block or limitation from something along the kinetic chain, then it's going to put increased amount of percentage wise of stress extra through that tissue, and over a chronic type of period, a chronic time, you're going to end up developing problems. So for example, Dan, for you guys who don't know what Schumann's is, it's just a increased thoracic kyphosis. That's mainly through adolescence, right?
Yes, it's considered a growth disorder, not dissimilar to scoliosis, except it's an anterior wedging of at least 3 vertebrae with associated small nodes, which is like nuclear empate. Indentations, it's kind of like multiple compression fracturing, if anything like that. It can actually occur anywhere in the spine, but most common with thoracics. There is a hereditary component, though they're not 100% certain how much of effect that has. But I also, I grew up from the time I was 11 to the time I was about 20 as a tight head prop.
Bro.
Yeah, boom. And as a tight head, you take all of the initial engagement. So, I had probably literal thousands of like impacts through the spine at that time. So obviously creating pressure. And then obviously there's, as everyone likes to forget, that people like to think of the body in 2D. So although there was anterior compression fracturing, it was more or like under wedging. It's more on one side. So I also have a left-sided lumbar scoliosis that comes with it because of that rotation. So obviously it changes fundamentally the biomechanics of that area.
There's heaps in that. So then you go into so if someone's got like Nath, look at Nath for example. I've treated him, you've treated him. What would that thoracic posture there create for like the scap and the shoulder and all that sort of stuff? Plus he's got the minus 5% extension on the elbow or something like that.
Yeah.
Well, I think like general rule is going to be, when you lose, if you look at it from a joint by joint approach, like what joints, obviously every joint has to be mobile and stable. It's not saying because you have one, you don't have the other. It's just like what's kind of like the energy systems in the body. You got all three energy systems going at once when you go for a sprint, but which one's dominant? It's like the same with the joints. If you look at the shoulder and the hip, in the thoracic spine, the rib cage, it's like, they're inherently designed to be mobile as their primary function. So if you get a joint in the body that's designed to be primarily mobile and you start losing mobility, like two things are going to happen. You're going to damage or overload passive structures at that joint, or essentially downstream of the joint that's stable, you're going to get relative hypermobility at the joint that's designed to be stable. And a joint that's stable with hypermobility is obviously not going to be beneficial either. And it's going to lead to overload of both potentially active structures like tendons and muscles, or potentially passive structures like ligaments, joint capsules, discs, things like that as well. So if you look at it from an upper extremity point of view, like if you have an alteration in rib cage orientation, alteration in the thoracic spine orientation, both of those things are connected. Like your ribs are connected to your T-spine. So with Nath, for example, he's got an alteration structurally to his thoracic spine, which is going to influence the position of his rib cage. And we think with the rib cage and the scap, it's almost like
scap lives on the
scapula is convex. Well, scapula is concave, sorry. The rib cage is convex, and they shouldn't sit like this together. If you've got like an altered position, like super flat or super rounded, it's going to mean that we now have like a dysfunctional relationship between the scap gliding on the rib cage. Scap can't glide on the rib cage properly, can't get efficient upward rotation, protraction like you need to get your arm overhead, get proper external rotation, flexion. If you can't rotate from the shoulder, then we're going to have to try and rotate downstream of the elbow. So it's like you can see the whole domino effect, cascade of events, which is coming from a structural thing. It's like if it's structural, our ability to intervene is going to be limited. Doesn't mean we don't try. We'll still try and improve it as best we can, but it means realistically, like if we compared me and Nathan's never going to have the same ability to get, shoulder rotation capacity like I am, because, well, we're starting from two different start points essentially, and that's something structural. So it's like we still respect its existence and work around it, but it means that from a predisposition point of view, it means that he's probably more likely to get issues like that at the shoulder and the elbow. Not to mention the fact it doesn't extend, obviously, which is something else. It's not not great. So yeah, I guess like combine those things. We've got a couple of structural issues there, and it's going to lead to overload of certain structures, which we can limit. But obviously, I'm not surprised by what he's got, and we just got to work around it. And then concurrently, from a management point of view, I'd be doing what Nath said, pretty much like, looking at the side of pain and looking at management, things that we can do to mitigate pain, desensitize, and just, manage, not exactly resolve, and then look at how we can optimize biomechanics as best as possible above and below, which it's never going to be. I think when I say optimize, is like what is Nathan's 100% versus what is a textbook 100%.
Exactly. Yeah. Maximizing is as
yeah,
much
like,
as you can.
Into his best capacity. Nathan's best capacity is going to be very different to my best capacity.
Yeah. And it's the classic focus of trying to outfunction structure, right? It's just like we may not be starting from 100%, but why not use 100% of what we do have?
I think so. Before I've got to run in a few minutes, boys. But before I'll leave with this. But
right. Mic drop moment coming up.
No, I mean, I think the easiest way I think about it is like we've all seen. Have you guys ever done physics in high school? Anyone do electricity? Yeah. So like think of electricity, and it's like you have the circuit, and there's so much voltage going through it, and you got resistance, and you got little different sections as well. Yeah. It's like if you've got 100 volts of electricity coming through and you've got two different directions it can go, like when it divides, it doesn't divide evenly, it divides more separate essentially. So it's like if we divide it, it's like you got different forces going through different areas, and it's like that's essentially like how the body's designed to work. It's like we then blocked off one of those pathways essentially. It's like you still got 100 volts of resistance, but now you got 100 volts divided over two areas, which means now maybe we're getting 60 30 10 rather than 30 30 30 or something like that. So it's like you look at it from a distribution point of view, it's like path of least resistance. If the body blocks off one area, which is, I can't rotate from my shoulder, I'm still going to get my arm overhead. Like, I'm still going to, or in powerlifting, it's very common because like what Nate said before, it's like you're doing bench pressing, you don't really have much of an option. You have to move around the bar or the other way around. If you can't pronate your wrist, you're going to internally rotate it and upwardly rotate your scap, which is going to create instability of the scap and overload the elbow. If you can't get the bar in your back because you can't externally rotate, you're going to either do this or you're going to crank the elbow again. You know, if you look at powerlifters, what are they doing? Bench press one day, squat the next day. If you don't have external rotation, internal rotation of the shoulder, you're going to be up shit creek without a paddle pretty fast, and your elbow is going to be copping it. So a lot of it comes down to looking at, like Nate said, you know, what's the actual task they have to perform? Because if you don't look at the task and if you treat a tendinopathy out of a textbook, then the person's never going to get better, because if you don't address the tasks they have to do and make sure that the profile of the exercise matches the profile of the individual, then that's where you're going to have disconnect.
Absolutely. I think that's
100%.
gold, bro. It's fucking gold. Mic drop.
Yeah,
He's out.
All right, I've got to run, boys, but it's been lovely.
All right, you go save the world, bro.
Bring it home for me.
All right.
Cool. See you, mate.
Very good. I think, yeah, perfect. Like the correlation between, and this is what comes down to taking a thorough history and also taking a special interest into the athlete's regime, for example, or the client's regime. So, for example, you know, in your case, I think even regenerative medicine would be worth touching on that. All right, well, I've got an event in X amount of weeks. I'm trying manual therapy. I've manipulated my training to this. I've changed my grip. I've done increasing my passive range of the shoulder, whatever that may be. I'm maxing out conservatively, but then, you know, certain things like PRP, growth hormone injections, etc., directly into the damaged structure, as well as addressing, you know, above and below. I think there's huge value in that, and that's where the knowledge of regenerative medicine and the physiology of the structure involved, which is the tendon. It's like, well, what is, as you said, like where is this thing along like the pathological sort of like lifespan? What treatments are relevant to acute and mid and end phase, or what's going to be relevant to a degenerative tendon, and does it need a fucking kick off the ass from some platelets re-injected into that degenerative or dead tenocyte, or does that just need a deload? So I think that for a lot of, you know, especially people who've got timelines on their events and that sort of thing, if I've got a client with like just chronic symptoms and this acute on chronic sort of tendon pathology, and it's non-responsive, or it's very slow to respond to conservative treatment, no matter, you know, and the person hasn't got 3 months to wait to run a proper loading program. I'm like, well, look, I said, I know a few guys who do PRP, which is the platelet-rich plasma injections, and they might do some cryotherapy, or they might mix it with some growth hormone, or they might even run you through some adipose stem cells if you want to go that option. So I think that the combination of regenerative medicine on top of the conservative management from all allied health professionals and the training, man, that's it right there. That gets tendon problems, that fixes tendons that don't fix themselves.
Yeah, I think it's a great option. Obviously, with that though, people need to be aware of like what's going in to their body, because certain federations won't allow it. Like if you've got HGH going in with that, you're going to get, you know, you're going to have one issue. So obviously, it's as always,
ASADA?
Understanding ASADA and all that. You have to know what you can and can't do. And for most of those, it should be absolutely fine, but there's others that may not be. So it's always on you as the athlete to know what you can and can't do. And there's always that line where you may just have to, you know, we're the last people to pull someone out, but sometimes you got to live to fight another day, right? You may do yourself more damage turning up to do this and put yourself out for another fucking year, rather than if you just sub this one out and live to fight another day. So it's one of the discussions that sometimes, you know, I think we've all had, and for crew that are athletes but aren't, you know, they're not pushing for Olympic selection here, right? They just want to do a novice fun comp on the weekend, and they're like, no, I need to make it. Sometimes you need to be like, listen,
risk to reward, right?
They're like, the value is not there. The value proposition is not here right now. And for you, our best option is just to get this sorted and bring you back so you come in doing well. Because otherwise the risk is you're going to go jump on and do this, and you're going to put yourself out for a longer time. Yeah,
that's huge. I think, like, I just had the conversation last week. It's not tendon related, but this dude came in, same age as me, 2 ACL recos, a hamstring graft, ITB, and then the second reco was the ITB and the patella tendon, which is quite stiff graft, and it's very effective. But he came in poor bastard. I had him in this morning again, and his quad and hamstring and calf on that leg was like sitting at 60% capacity compared to the other leg. It was his dominant leg.
Yeah.
He's like, bro, I've been doing 12 months of rehab, and I'm considering playing footy, and footy is like around the corner here. I'm like, man, I'm gonna have a honest conversation with you.
Yeah.
I'm like, are you getting paid to play? He's like, nah. You're just gonna play out because you're 28. You want to play the last couple of years with the boys. And I'm like, I don't know if anyone's told you this, but you would have some degeneration going on in arthritis, tibiofemoral, patellofemoral, potentially. I said, you had a couple of grafts, a couple of recos. If you do it again, this thing's going to be proper. Like it's already seen 4 major traumas. I said, you want to go for a 5th and then a 6th, another reco. I said, bro, your knee's it's had it. So I said, look, here's a 3 months worth of solid programming. I said, had the regenerative medicine chat with him. I took photos. I did some videos of functional assessments. I'm just like, look, until you get this leg and within a appropriate strength capacity of the other one with the hammy, the quad, the hip, and the calf, and the knee doesn't even hurt. I said, mate, then you should think about going back. I said, it's a recommendation, but it's a personal thing for me and a professional thing for me. I said, I don't want to see you rupture that thing again, especially with 2 previous non-contact ACL injuries. I'm just like, bro, I said, your risk to reward here is so far out.
It's too high, right? And like, I wouldn't even
contact
recommend
sport like footy. Like, geez.
But I wouldn't even recommend someone jumps in if they haven't done a full preseason, let alone someone's coming off something like that and just wants to jump in, right? Different story if he's talking to you and it's, it's September last year, it's starting to get better and we've got a whole off season to potentially work it
6
through.
months. Yeah, perfect.
Then there's an option right there, right? But right now it's like, all right, well, maybe if we want to get back to footy, we're goaling for the 2022 season, right? Because it's just like I said, like you hate to be the killer of dreams, but you have to be honest with people. As professionals, one of the biggest challenges is explaining to someone this is like the importance and severity of something without trying to scare them, right? Like we're not here to scare people, but we have to be honest. I can't just be like, that's not an issue, go do what you want. I have to be honest and say, listen, this is a real problem. We can sort it. We don't know how far we can sort it because, you've had multiple previous damages. It's never going to be 100% just by nature.
Structurally limited, yeah.
Yeah, but let's see what we can do, right? Like if you want to, like anything, he's 28, still got some good healing potential, growth potential there. You're like, well, if we were thinking more like 2-3 years of solid quality loading, rehab, and just getting better and better, well then we're setting you up for life to have no issues, right? There's no doubt in my mind that someone, if they do the appropriate stuff, can never have an issue with it again.
It's health, right? That's all. It's you're concerned about 20 years down the track.
Damn. Like you have to be concerned, but we should be concerned from not taking an active approach, right? Like I get really frustrated, and I know we're tangenting off here, but I think I think the listeners enjoy it, but I get really frustrated when I get clients coming in that have been told like they need preventative surgeries, right? Like, oh, you better have this shoulder recon now because otherwise in 20 years or 40 years, it's going to be rooted. You're like, man, in 20 or 40 years, who knows when medical care will be for that kind of invasive stuff? And it should be our job as human beings to try and wait as long as possible because every year we're getting better and better and better like options. The longer you wait, the actual better your options become, not the worse you get. And in most cases, taking an active approach early will negate these problems. Like we're seeing ACL rehab without surgery, right? We're seeing all sorts of different things.
Successful.
It just depends what the goal is. But if your goal is to stay functioning well, there's almost no case other than like if you've got a cancerous tumor where preventative surgery is a vibe, right? Like, when it comes to musculoskeletal, preventative surgery is not a thing. Like, if anything, it's a placebo idea at best and a nocebo probably at worst. Like, if we stop acting like the body is fragile and weak and start being more active and do better at getting guided and being more consistent. Yeah, people don't like to hear that you've got 2, 3, 5, 10 years worth of hard work to go through. But it's a lot better than like getting a preventative surgery and then not doing anything and you just keep shit in the bed and you're getting 3 or 4 of them, right?
Yeah, and you might outcome related, you might be in the same position anyway.
Yeah.
And if you've taken, as you said, that non-active approach and more of that passive sort of approach to management, it's like I said, you're in a worse off position than you would have been, and you spent X amount of money, and you've risked potential infections, this and that. So I think
it's a
take-home
it's a question
story,
of disability.
Yeah,
huh?
The take-home story is just for musculoskeletal management, there's nothing better than conservative, like strength and conditioning training, and like I think we run another podcast on determining like, who should qualify for this type of rehab and conservative treatment, who should be a surgical client, weighing up
100%.
not only the presentation, but all right, is this personality type? Is this person committed? What are their goals like? So I think that's really good. I think that's a good tangent to finish it on, because that's a real case, conversation and experience that you will go through if you are a health professional, where you have to take enough responsibility as a health professional and, as Nate said, being a human about it and say, look, mate, this is personally where I'd go. This is professionally what I would do. At the end of the day, everything's a recommendation. I ain't got a gun to your head and saying you have to do this. I said, there's no obligation for you to even come back and see me, but I truly believe this is the best option for you based on X, Y, and Z. And mate, if you can tick all the boxes in 3 months' time and you're feeling really good, mate, why not have a crack? I said, at least you're giving it a go, but don't
100%, right?
shoot yourself in the foot and end up fucking yourself over and, just end up disappointed. Anyway, let's finish it up there. I think
let's lock it in there.
You guys hopefully enjoyed it.
Yeah.
There's a lot of gold in that, I thought.
Go, Ben. I believe in you in closing it out.
All right. So, guys, if you enjoyed it, pay the fee. We're copying the old Andy Frisella. Pay the fee. Share the episode on your socials. Talk to someone about it. We're definitely not popular enough to run ads, so we can't even use that excuse that we're not running ads. We're choosing not to run ads because you guys are going to keep us alive. And we're not at that stage, that's for sure. But
if someone sponsors,
share some info.
Shit, we probably would take it.
Share the love. Tag Nath, tag Mina, tag Daniel, tag myself. I'm sure we're gonna have an Instagram up and running soon enough. But that's all right.
We're coming to the party. All right, everybody. Pleasure as always, and we'll talk to you soon.
See ya.